Hello everyone, and welcome to this short video about tonsillectomy and/or adenoidectomy. We'll talk about what your tonsils and adenoids are, why they might be removed, and how we care for a patient who has had them removed. First, let's do a brief anatomy review. Your tonsils and adenoids are this vascular lymph-like tissue located at the back of your pharynx. Some of it's up more behind your nose, and these are the areas we usually call adenoids, even though they're the same tissue as your tonsils. And then what most people think of your tonsils is this tissue at the back of your throat. We can usually see it when we're inspecting someone's oral pharynx. Notice that these adenoids are near where the eustachian tubes enter the airway, and the tonsils are part of the main airway connected directly to the trachea. Both of those anatomical locations are an important factor when we consider removing either of these tonsils or adenoids. Now let's review why someone might have their tonsils or adenoids removed. A few decades ago, it was actually quite common for people to have their tonsils taken out. They were sort of viewed as, why do you need this anyway? And so doctors would just sort of remove them at the slightest little indication. The more we learn about the tonsils and adenoids, however, we realize they really do have a function closely related to your immune system. So now we have specific guidelines about who is eligible for tonsil or adenoidectomy. The first indication would be recurrent infections. This could be infections of the tonsils, which we call tonsillitis, or it might be recurrent ear infections. Remember that the adenoids are close to where the eustachian tubes enter the back of the throat, so if they're extra enlarged, they can actually be blocking drainage from the eustachian tubes. Or sometimes we actually see abscess formation in that tonsillar tissue. The other reason people might have their tonsils taken out is obstruction of the airway. This is usually manifested as sleep apnea. Remember that apnea is defined as a pause in breathing for 20 seconds or longer. So if those tonsils in the main airway become enlarged, they can actually block off the airway, especially when the patient lays down to sleep. In the description, I'll include a link to another YouTube video that shows a little kid with some significant sleep apnea caused by enlarged tonsils and adenoids. For the procedure itself, remember that the tonsil/adenoid tissue is very vascular, so the procedure is quite traumatic to the tissue surrounding it, and there can be a fair amount of blood loss. This becomes one of our main priorities as we're assessing the patients post-op. So, of course, part of assessing for any kind of blood loss is careful monitoring of vital signs. If there's excessive blood loss, we'll see that decrease in blood pressure, decrease in pulse ox, increase in heart rate and respiratory rate. So we'll do our routine vital signs, Q 15 minutes times 4, Q 1 hour times 4, etc. But if we have any concerns, of course, we can monitor even more frequently. The next major assessment that we'll be completing is observing for bleeding. So there are a few things we look for. First, we just visualize the throat. And if we see a lot of bright red blood just draining down the back of the throat, we would need to notify the provider. Of course, if the patient also starts spitting out or vomiting out large amounts of bright red blood, that would be another indication that there is active bleeding going on. Sometimes the patient just swallows frequently, and we are suspicious that it's actually blood they're swallowing rather than saliva. For really young kids, they may just appear restless or cranky. We also keep in mind that bleeding is most likely to happen in the first 24 hours or about 7 to 10 days post-op. course, the first 24 hours is when the tissue is first healing, and then 7 to 10 days post-op is when some of the healing scabbed tissue is starting to peel away and it can reopen blood vessels. In addition to the bleeding risk, most people are aware that it's a painful procedure, so pain management is another important priority for us. And this is actually where practice has changed in the last few years. Acetaminophen with codeine used to be our #1 pain medication post-op, but the FDA has released new black box warnings, and we no longer use any codeine for any patients under the age of 18. What was happening is that certain children are what we call super metabolizers, and their bodies would take the codeine and turn it into extra concentrated doses of the same chemical and morphine, and it would suppress the respiratory drive, and children would actually develop significant apnea, and a few patients even died. So the FDA has now said no codeine for any patient under the age of 18 years old. Because of that, we've had to reassess pain management in these post-op patients. So acetaminophen is still used. Ibuprofen is also a popular choice. It used to be avoided because people were afraid of increased bleeding risk, but new research has shown that that bleeding risk is actually very tiny, and most patients do quite well on ibuprofen. If we need it, we need something a little stronger, patients may receive hydrocodone, but we would use the smallest dose necessary and only use it for the first day or two of post-op recovery. Of course, with any of these medications, we'll make sure that the patient and/or the parents are well educated about the dose and the timing of those doses. After the first few hours of post-op recovery, some patients will go home. Their procedure was an outpatient procedure. Other patients will stay overnight in the hospital, what we call an inpatient admission. Older patients who had their tonsils removed for an infection reason are more likely to go home. Younger patients who had their tonsils removed for obstructive sleep apnea are required to stay 24 hours in the hospital. And anyone in between, it's ultimately up to the surgeon completing the procedure to decide whether they'll be admitted or not. Before we send any patient home, of course, we want to make sure that they know all the ins and outs of post-op care. So one of the first things we teach patients about is minimizing bleeding. Remember that bleeding or hemorrhage is one of our main post-op concerns for these clients. So we have a few suggestions for families. First of all, we need to limit blowing the nose or clearing the throat. Patients may feel like they have a lot of buildup of mucus in those airways because of the procedure, but if they're repeatedly blowing their nose or clearing their throat, they could actually be reopening wounds and restarting the bleeding process. To help keep any mucus moving, we do recommend cool mist or humidifier, just to keep those airways nice and moist, make sure there's no buildup of any kind of scab or dried blood. We also want patients to be very gentle with the whole area. So this applies to things like brushing teeth, using only a soft bristled brush, making sure to be very careful not to accidentally stab themselves in the back of the throat while they're brushing, avoiding sharp foods, so this is things like crunchy chips, bread with a hard crust, fruits like berries with tiny seeds in them, really anything that could sort of scrape the throat on its way down. Many people have the preconceived idea that you have to eat only cold foods, especially ice cream, after you've had your tonsils out. And it is true that many patients do well with the cold because it helps to sort of numb the throat as they're swallowing. But there is no restriction that you can only eat cold foods. In fact, I distinctly remember one little boy who would only eat chicken soup after he had his tonsils out, and that was fine. We were okay with the chicken soup as long as he was taking something down. Another part of being gentle is to avoid straws. When the patient uses a straw, it increases the suction on the back of the throat and can again kind of pull at that fragile tissue back there. And then finally, we just ask patients to be careful with their activity for 2 weeks while their throat heals, just avoiding extra vigorous activity, just to allow that tissue a chance to really heal up before they start to put too much stress on their system. As I already mentioned, the procedure itself is quite painful for the back of the throat. So after we discuss minimizing bleeding, we want to make sure we talk about getting enough intake. So when we're discussing avoiding the sharp foods, we'll also give tips about certain things that may encourage the patient to take more fluid in. For example, drinking a cup of Pedialyte may not go over well, but maybe sucking on a cold Pedialyte popsicle will be okay for that patient. When in doubt, parents need to keep track of how often their child is peeing, and if they have a decrease in urinary output, they need to contact their provider. We also make sure to talk about the normal healing process with patients. First, we warn that ears may actually hurt. And this is just referred pain from the back of the throat. So we warn them ahead of time so they realize a little bit of ear pain does not mean to run to the doctor looking for an ear infection. Just wait it out, try some pain medication, and see how you do. We also warn that the patient will probably have some bad breath, some mouth odor, and maybe even a low-grade fever, especially for the first few days following that procedure. We also like to warn patients that this picture demonstrates what the back of the throat will look like. All that white tissue back there is actually healing happening, but patients are concerned that it's pus or that the skin is peeling away, but this is actually a normal expected finding. Certainly if they see any bright red back there, then we want to know about it, again, because we're worried about that bleeding. And the last piece of patient education is just the follow-up. So we would like to see the patient back at the provider's office, usually in about 10 to 14 days post-op. And if the provider has not already given instructions about returning to full activity, then they will do so at that point. Okay, so that's it for tonsillectomy and adenoidectomy. We talked about the indications for the procedure. We talked about the post-op care. And we talked about patient education. As always, if you have any questions, contact me, email me. I'm happy to help.